Hello, everyone. Welcome to this afternoon's PQA Quality Forum Webinar. My name is Amanda Ryan, and I am Director of Education here at PQA. Today's topic is Barriers to HIV Care, a pharmacy-based pre-exposure prophylaxis, also known as PrEP model. As usual, I would like to call your attention to 3 housekeeping items on the next slide. First, I encourage you to please submit your questions during the presentation using the Q&A feature that you will see at the bottom of your screen. We'll have time for extended discussion today and look forward to including your questions in the discussion. Second, the webinar recording and the slide deck will be available to PQA members within a week following the webinar, and that will be on the member resources section of the PQA website. Additionally, we will have a recording posted to PQA's YouTube channel. Lastly, I would like to encourage all attendees to complete the quick 1-minute survey that appears at the conclusion of the webinar. And with that, it's my pleasure to introduce our speaker for today. Tony Minetti is the owner and pharmacist in charge of Camden's Bell Pharmacy. He is a 1993 graduate of the Philadelphia College of Pharmacy and Sciences. His career in pharmacy began in 1984 when at age 14, he went to work at his grandfather's pharmacy. After graduating, he joined his grandfather's business and they purchased Bell Pharmacy in 1997. He has maintained sole ownership of Bell Pharmacy with his sister and fellow pharmacist, Marion Morton, since 2013. Bell Pharmacy is the 2021 winner of the Community Pharmacy Innovation in Quality Award in the pharmacy category, which we announced at the PQA annual meeting, and that was in collaboration with the Community Pharmacy Foundation. The award honors a community pharmacy whose innovative practices improve care quality and also focus on medication optimization and patient outcomes. Award nominations and their contributions to community pharmacy were evaluated for their innovation, their measurable impact, replicability, scalability, and reach. Priority areas of focus were programs that addressed vulnerable populations and gaps in quality or patient care, as well as the quadruple aim of healthcare, which includes the patient experience, population health, reducing costs, and care team well-being. Tony, congratulations to Bell Pharmacy for this year's award, and thank you so much for joining us today.
Thank you, Amanda. And thank you to all who are attending and learning a little bit about what we're doing with the pharmacy-based PrEP clinic model. First, a little bit of history about who we are. Bell Pharmacy is a 340B certified independent neighborhood-owned pharmacy. We offer comprehensive solutions to address community needs. We're Camden's oldest family-owned and operated neighborhood pharmacy, established in 1931 at the corner of Haddon and Kane Avenue in the historic Parkside neighborhood of Camden. Bell Pharmacy remains committed to personal service provided by neighborhood pharmacist owners, evolving and expanding to accommodate new community needs. While maintaining our core mission as a traditional neighborhood pharmacy, the practice expanded to address unmet needs, including mobile immunization clinics, HIV disease management, PrEP counseling and testing, substance use treatment, overdose prevention, and naloxone distribution, as well as comprehensive specialized services for the LGBTQ community. Bell Pharmacy owns and operates Amstar Medical Transportation, a non-emergency ambulance and medical transport company, to address gaps identified in collaboration with Camden Coalition. A true neighborhood collaborator, Bell Pharmacy provides a one-stop solution to the complex care needs of Camden's most vulnerable populations. For innovations, in July 2020, Bell Pharmacy, an independent neighborhood pharmacy in partnership with Camden Area Health Education Center, opened New Jersey's first pharmacy-based PrEP clinic practice model. It was established to address the needs of vulnerable populations in Camden. The pharmacy-based PrEP clinic practice model expands and enhances existing pharmacy-based practice model or pharmacy-based models where pharmacists assume a lead role in preventative treatments. For example, vaccine and immunization administration, overdose prevention through Narcan dispensing, among others. The PCPM creates a one-stop source of education, clinical services, and pre-exposure prophylaxis, as well as wraparound services. It is a one-stop hub for health education, clinical services, and PrEP treatment and community services. The vulnerable populations Bell Pharmacy's model serves include women of color, partners of people living with HIV, injection drug users, people living with substance use disorders, and the growing LGBTQ community served by our neighborhood pharmacy. Over 90% of residents are people of color, ethnic minorities, with 49% identifying as non-Black Hispanic and 41% identifying as Black. New immigrants from the Dominican Republic and Central American countries of Guatemala and Honduras, as well as a large representation of people of Puerto Rican ancestry reside in Camden. So the concept of developing a pharmacy-based PrEP clinic practice model began in 2017. The approval of Truvada for PrEP occurred much earlier in 2012, but acceptance by the broader medical community and public did not gain momentum for several years. This was likely due to caution and skepticism about a groundbreaking claim that there was a drug therapy that could prevent the transmission of HIV from infected to non-infected individuals. As the use of Truvada for PrEP began to gain acceptance, Bell Pharmacy saw the potential for community pharmacists to play a central role in advocating for the use of this life-saving treatment. Some of the key actions that were taken to innovate the first New Jersey pharmacy-based PrEP clinic included a pharmacist obtaining advanced accreditation in HIV disease state management, pharmacist completing the American Academy of HIV Pharmacist certification course, a pharmacist completing the state certified PrEP counselor training, and designating a pharmacist as clinical director of HIV services. And this would be for an application to prescribe and dispense Truvada, something that's still pending in front of the state of New Jersey. The advantages to having PrEP clinics co-located within a pharmacy to advance community pharmacy healthcare quality and outcomes for vulnerable populations include access to recovery resources for people with SUD, OUD from an appropriately credentialed pharmacist who can discuss, prescribe, and dispense naloxone. People receiving medication for treatment of opioid use disorder can receive counseling about PrEP from their pharmacist and be directed to the PrEP counselor for education about options and navigation to community services. Community STD programs can outstation syringe exchange programs at the neighborhood pharmacy, and others can access new syringes directly from the pharmacy at low or no cost. Sexually active women have direct access to birth control methods, Plan B condoms, not typically available at a non-pharmacy-based PrEP clinic. Providing concomitant vaccines and immunizations alongside PrEP counseling visits offers a critical opportunity in our post-COVID-19 health landscape, with lab tests conducted on-site to eliminate the need for an additional trip and avoiding a missed opportunity for patient engagement. Those with an HIV STI positive test result, having an established relationship with a pharmacist to address concerns about treatment initiation, can augment and provide counseling and support. And there's on-site access to transportation services through the non-emergency medical transport that facilitates access and improves attendance. Most importantly, we have immediate access to the first month of PrEP medication. Okay, so I think we've cooked through several of our items, not exactly in the order of our. Yes, thank you, Amanda. Or not in exactly the order of my comments. So we look to the partners that have helped make the pharmacy-based PrEP clinic model a success. Bell Pharmacy partnered with Camden Area Health Education Center, a certified PrEP clinic, to facilitate community outreach. We use a single point of data collection using a unique patient MRN. PrEP counselors get real-time insurance information and prior authorization from the pharmacist, and patient management is enhanced through the retention and adherence that we gain with the synergy of having the PrEP clinic integrated into the pharmacy proper. Typically what we see is a bifurcated process where patients are with a doctor one visit, with another pharmacy a different visit, going to lab. There's lots of potential for drop-offs, and the information doesn't flow consistently because there's no interconnectivity between all the different providers. We have software service options that allow the PrEP counselors to work alongside the pharmacist to maximize patient outcomes and also collect the important data, which is a key feature of New Jersey's PrEP clinic program. We also have web-based services that allow for 24/7, 365 access to a PrEP counselor. Bell Pharmacy also formed an alliance with ACOA Consulting. It's an internationally recognized team skilled in the strategic planning and guidance for health and human services, public health research, and government programs. ACOA helped expand our model from being a solely PrEP-based model to include many of the substance use disorder and risk mitigation and management strategies that have helped grow the model beyond just a PrEP model. When we talk about quality improvement, the community collaborations that we formed led to continuous patient contact, and it allowed for outcomes to be documented regardless of location of service delivery. What we felt was by using the pharmacy as the central hub in the wheel and having those connections directly to the PrEP counselors and the community organizations who handled outreach, as well as collaborators like ACOA Consulting, that everything flowed to the pharmacy that maintained the central record of the patients and facilitated all the interconnectivity among the different, once segmented, partners in treating patients for PrEP therapy. So when we came to outcomes, our sample was somewhat small because we launched our process right at the same time that COVID was coming onto the scene. However, in the small population that we did manage, we were able to determine HIV and STI status. Those who were eligible were initiated on PrEP treatment, and all those who initiated PrEP treatment timely refilled their prescribed medications for the measuring period at 6 months. We did not lose any patients from the program, which was very important. And again, it gave us the ability to get this information through the PrEP clinic counselors to the New Jersey Department of Health so they could measure the effectiveness of the PrEP clinic program. So when we talk about what's next, the goal obviously is to continue to grow the program and use our unique ability to touch patient lives that would normally not access this degree of care, to offer a wide range of services that vulnerable populations would need. Pharmacies have the ability to do immunizations. We can do updates of affected patients to assure that all their immunizations and vaccinations are current. We could test for STIs and Hep C. If a patient is positive for Hep C, they have the ability to be directed to resources to manage Hep C. This is also a huge issue among our vulnerable populations. Those who are negative for Hep C, of course, we have the ability to get them vaccinated. And of course, in the post-COVID world, we have the ability to provide vaccinations and the prescribed boosters as of today to our PrEP patients. But what this does is by using the PrEP interaction as sort of the gateway to the experience, it gives us the ability to really manage the patient's entire health, which is so important when we're talking about the vulnerable populations and in the urban environment. So that is a brief overview of what it is that we do. I will tell you that I am much better at answering questions and talking to questions than simply presenting. So if you have questions, I think that's going to, it's really going to open up the conversation, and I think we're going to get a lot of information and, and good dialogue from that. So Amanda, if you have any questions, I see a few in there in the Q&A box.
Okay, yes, we do, and Tony, rather, and thanks for that intro. We can certainly have a conversation now. Remind the audience, please do keep those questions coming. We've got a few, but we will address as many as we have time for. So if you think of any, please let us know what those are. Tony, I'm going to start with a question that really just gets back to the beginning of how you determined the need for this clinic and how you decided that your pharmacy could fill that need. So you mentioned Truvada and the increasing utilization of that for PrEP therapy, but what else besides that really was the impetus for getting this model started?
Well, it goes to sort of what my vision for the future of community pharmacy holds. Community pharmacies need to migrate away from the dispensary business model, or the model of selling sundries and items like that, and we focused on becoming more of a healthcare hub. What we're experiencing, particularly in the urban communities, is a situation known as pharmacy deserts. At one time, urban communities, which are so diverse and have all different neighborhoods, every neighborhood had their own community pharmacy that was tailored to their specific need. That's largely gone in the urban communities today, and one of the problems that we see is when the chain stores move out, our most vulnerable left with few options. So this seemed to be a natural extension of what my vision for what community pharmacy should be. Again, we view ourselves more as a healthcare resource hub, and offering these sorts of services when we have a population that's considered a hotspot in New Jersey, or an area of dense population of those that are vulnerable or in need. This just seemed like the natural extension of how we could really help our state achieve the HIV-free by 2025 goal.
So really evolving the practice of pharmacy to meet that need and to help support that goal. Sounds like what you're working on. Yeah.
Yeah, I mean, it's interesting because prior to writing, when we actually submitted this, pharmacists were only just then getting into dispensing or administering the COVID-19 vaccine. And I think one of the things that we learned was you had mega sites and you even had chains in certain environments, or particularly in the in the urban environment. And they found that those models of one size fits all wasn't really working very well. And when community pharmacy was given the ability to apply their micro approach to their neighborhood, we saw vaccination rates increase, we saw acceptance increase, we saw hesitancy decrease. And something called vaccine frustration is what we experienced in our neighborhood, which is largely African American, where they felt like we just can't get access, why bother? So we started with this PrEP clinic model, but what really showed us it could work, ironically, was the way that we were able to perform and step up as pharmacists and healthcare professionals during the COVID-19 vaccination push. So the success of the vaccinations really affirms that these sorts of community-based programs, if applied and replicated throughout different urban environments, will work. What I like about this model is, much like the vaccination program, it's easily scalable. Any pharmacy that experiences at need or vulnerable populations can join with a community partner like we did and bring this model to their community, but tailor it to that specific community. Ours is tailored to the largely African American population of Parkside that we serve. We have also tailored it to the surrounding areas, but what works in Camden, New Jersey may not work in Des Moines, Iowa, or say every neighborhood pharmacy has the ability to install this sort of program, and it's something that's unique. It's something that the chain stores won't do, and it's something that really builds relationships between the pharmacy and the community, and it continues to reinforce that concept of community pharmacy as the center or healthcare hub of a community.
So speaking of the community then and the patients that you serve, we've got a question here about the number of patients. So I think you mentioned the small group of patients that you serve. So curious also, I'll add a little bit to this question about the number of patients that you started with this model and how many you're currently serving, and if you feel like you even have additional capacity beyond that.
Sure. We started off with obviously, none, but through working with Camden Area Health Education Center and their outreach program, we quickly grew to approximately 15 patients, which is where we are now. Unfortunately, right as we were really getting the program moving, the state imposed the lockdowns, and we went into that period of late March, early April. Pretty much. We all know how that went with COVID until recently, where we've been able to pick it up. Now, we were able to continue to manage patients during that time because the pharmacy continued to operate, but outreach was more difficult because of just the restrictions and the social distancing. We're now getting back into that and being able to have groups of individuals in the pharmacy and bring people in and have a lot of that interpersonal interaction that we haven't been able to have up until this summer on a full basis. So where we started was very few. We quickly ramped up to about a dozen to 15 patients in the program. We've maintained them, and that's kind of where the program is now. And we just met with the New Jersey Department of Health today about seeing how we're going to continue to grow this program.
So sounds like positive conversations happening at the state level for sure. So expanding, we got a question actually just now related to continuing to expand. So, well, what barriers and facilitators are in the environment that are going to play a role in your expansion of the program?
Well, I mean, first of all, the success of the program will also be driven by word of mouth. I mean, many of those that constitute the vulnerable population group that we speak of are almost a community of their own. And when they've had a positive experience, or when others see people have gotten well, that's going to encourage more to embrace the idea. Right now, we have a model where community facilitators go out and they almost try to recruit patients to come in and to get them started on PrEP, or give them this idea that let's pay attention to our health. One of the other positive things about the COVID situation is, with the huge push for vaccinations and preventative treatment, now you're starting to see people embrace concepts like taking Truvada to avoid getting HIV, where they were hesitant about the idea of taking a vaccine or accepting something like that they were unsure of, because of the intense spotlight that's been on the response to COVID. That's really helped lower the barriers to hesitancy that we once had with going in and proactively trying to prevent acquisition of a disease. So that's, again, COVID has been negative in so many ways, but there have been bright spots, and one of those are raising awareness of the importance for preventative treatment and vaccine. So yeah, so when we talk to what the, I guess I think I answered that one. If I didn't, we could rephrase it another way.
Okay, for sure. Yeah, I think that gives us some things to think about. A lot of different directions this could go in the future, and excited to see how this continues to expand. Related to PrEP, then we had a question about adherence. So, how do you ensure patients are adherence to their PrEP therapy? How do you measure that? How do you monitor that? Any tips for doing that for anyone that might be interested in doing something similar?
Sure. What's great again about this model is that it's got an integrated approach among the different collaborators. Camden AHEC is wonderful at outreach. That's something that would be difficult for the pharmacist to do if they're operating a pharmacy. Obviously, for the pharmacist, you have to be there. You can't be out going to community meetings. You can't be out interacting with those who may be in need or those that are in the vulnerable population. Camden AHEC is free to do that. What we as pharmacists obviously specialize in is the maintenance of the patient's medication, and maximizing their adherence, and also giving the ability to pre-plan. For instance, the counselors don't really know, outside of whatever they jot down, where their patients are with their medication. PrEP, you have to have lab tests every 3 months. So when and you're only going to get 3 refills of the medication, then you have to have a lab test. Or maybe you've had the lab test, but you haven't re-interacted with the primary provider to get a new prescription. What the pharmacy has the ability to do using compliance software, which most pharmacies have these days, is when that 3rd refill has been achieved, we have the ability to go to the PrEP counselor and say, okay, our patient just got their last refill. They're due for their 90-day labs. Let's get that scheduled. Let's get them to the labs. And by the way, as soon as you get those results, get them to me. I'm going to get them to the primary physician so we could get the next 3 months of medication ready to go. This way, there's a seamless continuum of care. We don't wind up with gaps or other delays. When you break that routine that the patient is in, there's a high likelihood that it's going to be extraordinarily difficult to reinitiate once they've sort of broken that therapeutic habit. So the goal is that when the 3rd refill is expired, they're right to the next one, and everything in between that's been taken care of is something that proactively the pharmacist and the counselor can work on together. Also, we have the ability to communicate with the patient a little more effectively through text messaging. We have their demographic information. A lot of times, patients tend to be somewhat migratory in their situations, and if we're unable to contact the patient, we can immediately get in touch with the PrEP counselor, who can get out in the community and reestablish contact, and again make sure that continuum of therapy is not broken. Making sure that this is taken daily, every day, continuously is the secret to it working.
So I had a question about continuous daily PrEP. We know, of course, sometimes exposure to HIV is an intermittent thing. Do you do a model with intermittent PrEP therapy at all, or is it only a daily therapy? And have you considered an intermittent model?
Well, we do have the ability to do PEP, the post-exposure prophylaxis, when somebody knows they've had an exposure. Mostly, what we're focused on is the PrEP side of it, which is it's difficult to know that somebody has had a true exposure versus a high risk interaction. So we typically focus more on making sure they're on PrEP, because as long as you're on PrEP, having those interactions, you have a 98% chance of not contracting HIV from an HIV positive interaction. So really the goal is to keep them on it, because if they're on it, regardless of, they don't have to worry about status or safety, which is a whole other issue, because there is a concern that PrEP therapy can encourage non-safe practices. But we cover that also. We cover the need for continuing to practice safe sex, and if you're suffering from opioid misuse or opioid use disorder, continuing to follow habits that are not going to put you at risk, even if you are on PrEP. But that's the whole thing, is that with PrEP, it's proactively protecting the patient against HIV exposure.
And then a few moments ago, you mentioned the role of the PrEP counselors and how important they really are into helping with adherence and really partnering with you in the work. We had a question about their training. So is there anything else you wanted to add about the PrEP counselors' role and what their training might be?
Yeah, and this is, I recommend that all pharmacists should undergo the PrEP counselor training course. I was the only pharmacist in my training group of approximately 35 counselors. And so much of what we built into our model came from the experience of seeing what the counselors do on their side. Most of the counselors are social workers or licensed in that sort of profession. They're not pharmacists. I realized how important that social aspect is, just through the strategies of the way that they talk and the way that they speak with those who are vulnerable, and get them to come around to this idea of accepting PrEP therapy, which is so much of it. I'm medically trained. I'm not trained in social work and interaction, and I learned so much just about little things that you would take for granted. The way that you approach a patient, the way you discuss, the language you use when you discuss certain issues. Recently, I think we've seen a change from sexually transmitted disease to sexually transmitted infection. It's little things like that, believe it or not, make a big difference. And we're not typically trained in that fashion, but the social workers who are outstanding at it. And I identified quickly that really that was, my weakness was their strength. And I think that at the end of our 3 days of doing the counseling course, I think that they learned a lot from what I brought to the table. And I certainly learned a lot from watching what they do. And that helped refine this model down, because I learned what the social workers have to do, what they go through, what their challenges are. And we built our model with the intent that it would make the social workers' job as easy as possible. And pulling all that away of having to make different appointments and get the patient here one day and the next week get in touch with them and take them somewhere else, bundling that all into one experience, into 145 to an hour interaction inside the pharmacy. It was terrific. And one of the things that also I learned from the social workers were the degree of comfort that patients had going into a pharmacy as opposed to going into an STI clinic. When you go to a PrEP clinic, everybody knows what you're going there for in the public. When you go to a pharmacy, you're another customer at the pharmacy, just the same as the person who's coming in and getting their prescription for ibuprofen and their Z-Pak. So the stigma sort of dissipates, and people are a lot more comfortable and a lot more willing to go into a pharmacy than they would be to necessarily go into Camden AHEC, where somebody may see them go in and knows what they're going in there for. Again, these are all the little things that you learn when you bring together the social work side of it with the medical profession side.
So truly an example of teamwork and everyone bringing their strengths to the table. And the stigma you mentioned, the way that pharmacies can really help to alleviate that stigma sounds critical to this program. So that's very, very interesting and something for us to consider as well. We had a couple, go ahead.
One of the, and along the lines of the stigma issue. One of the populations that we really didn't address in the brief overview that I gave was the idea of utilization of telehealth to outreach to the just becoming sexually active teens. We have a whole portion of this model that speaks to telehealth, to outreach to sexually active teenagers through apps like Grindr and making them know that, hey, you could get on your cell phone and you could have the visit, and the pharmacy can get the PrEP to you. You won't even have to leave. Now, again, when we developed that, telehealth was something that nobody was even embracing. But again, one of the silver linings of the COVID era is that telehealth suddenly became a thing. People embraced telehealth, and they saw the potential that we saw in it, where you can reach people who, the teenager who is just becoming sexually active that maybe does want to get PrEP, but how are they going to get to the doctor? This is an outreach that takes us beyond our vulnerable populations traditionally that we built this model for, and it allows us to reach out into the suburbs that are more affluent, but either through, young adults are shy, they don't have transportation, but they all have a cell phone, and they can have their medication delivered, and they can start to practice, they can develop safe sex practices at a very early age. And that's really, when we talk about the vulnerable populations, they're sort of already, exposed. You're now able to get to a population that's younger and help them learn about safe habits in a confidential fashion without them having to go to a doctor, a counselor, or a meeting or anything. All of this could happen through a phone app. And the fact that that's now more mainstream is just a terrific development, and will really help enhance this model that we started before that was something that everyone did. So I'm sorry, Amanda, I just wanted to get that in there before I forgot.
No, it was very good points. Finding those silver linings and figuring out how to make healthcare better despite everything that has happened with COVID. It's exciting to see that we can find those small silver linings. We've had a couple of questions come in related to staffing. One was around requirements of the New Jersey Board of Pharmacy about HIV specific training. So what were those requirements? Did you have additional specific requirements for your staff before you put this model into place? And then if you could just give us an idea of the sort of staffing time this takes. Do you have someone dedicated to it? Is it a team effort? And about how much time your staff spend on the program?
Sure, these are great questions. The Department of Health and the Board of Pharmacy have no specific requirement for HIV training for something like this, because the Department of Health is only now, through us rolling this out, through the recognition we gained, by being awarded the Innovation Award by PQA. Now they see it, and they're starting to embrace this idea and look at it more closely. I built into our model only because I felt that it was necessary. Two components. A pharmacist has to go through that PrEP training course or something similar that helps them understand the social work side of this beyond the technical prescribing side. But we also, this model calls for an accreditation through an agency like the American Association of HIV Practitioners, where you take advanced training in HIV treatment. The idea was we don't want this to become another mail order service. We wanted to do something that would be difficult to replicate in a chain store model where the prescriptions are going to get generated off to their PBM and contact's broken and the medication just gets shipped. That's not the model that we wanted. We wanted a truly interactive, collaborative model that had more patient contact and patient care and patient management. We did not want this to be a dispensing exercise. So those aren't required. I've spoken with the Department of Health and recommended that if this is a model that they adopt in some sort of pilot capacity, that they do require those accreditations. And only, not because I don't believe that pharmacists are accredited. I believe that the counselor training course is unique and absolutely should be a prerequisite. I believe that all of the graduating pharmacists, yes, are very well trained in HIV and other infectious disease states. However, I think that you need to have that accreditation only because you have to continually reapply for it. And it really helps you stay on the cutting edge of what's happening in the world of infectious disease. Keep in mind, Truvada is not new. It's been around for years. Only in 2012 did they start to use this idea of pre-exposure prophylaxis, and it was only in African countries. It didn't even really get to the United States till about 2015, 2016, and even today, the only reason that you probably know about is if you watch Comedy Central and you see the Truvada and Descovy for PrEP. If you're not constantly learning, and you don't, you get complacent and you're not keeping up on that certification, you're not staying on the cutting edge of these sorts of therapies and what's new and what's happening. And that's the only reason I recommend an accreditation in HIV disease states. For the record, I typically oppose these accreditations because I think that they're arbitrary. This one is one that I do believe is helpful and should be a component of any pharmacy-based PrEP clinic.
All right, thank you, Tony. Appreciate your insights on that. Got a couple questions related to financial issues. The first one is just about funding for this model. How is your pharmacy funded for this model? And do you have any tips for others who might like to set up a similar model to obtain funding?
Great, Amanda. And this probably goes along with a portion of the last question that I sort of neglected, but I think it actually fits better here. And that's how do we staff and run this? The way we did it is we created a dedicated area, maybe 200-300 square feet of our pharmacy space that we created a separate room that is the quote PrEP clinic. We've since had to co-opt it for the COVID vaccinations, but it still is ready to go, where we've donated that space to Camden AHEC, which is a nonprofit. So if we want to look at a financial benefit right off the bat, you can use a tax write-off since they're a 501c3 for the value of what rent would be. Again, not a huge thing, but every benefit, especially in community pharmacy these days, does count. They, in turn, they manage the program of getting patients in and do all that. So that takes the burden off of us as the operators of the business to have to be out there constantly trying to recruit new patients. A very lucrative opportunity is if the entity that you partner with is a 340B eligible entity. That gives the ability to participate as a 340B pharmacy, and the reimbursements that you get as a participating 340B pharmacy are far and away superior to what you would get if you were non-340B. And it also has the ability to, it not only financially improves the position for the pharmacist in the pharmacy, it also helps the nonprofit continue to build and expand their program and their resources, which in turn helps the pharmacy grow. As far as extra workload, I don't know that there's a lot because so much of what we do already as pharmacists is just carried through on this program. As pharmacists, we already make sure that refills are being filled on time. We already interact with physicians to try to make sure there's not gaps in therapy if patients run out of medication. We do warn patients in different instances about the need for lab tests or the need for follow-up visits. So we do all that already. But this applies it a little more specifically, but it also allows us to develop a cohort of patients who are going to be supportive of the pharmacy in a financial sense. I mean, you're getting patients who have built a relationship, and those patients are not likely to be poached by Credo or any of the chain affiliated PBM specialty pharmacies. So we found that the interaction is really what holds the patient and keeps the patient with with the pharmacy, with the counselor, and it's not something that's easily undermined by any of the aggressive forces of the PBMs or the chain pharmacies. So, in conclusion, you don't have to do a lot more to gain a patient that will be your patient for life, or as long as they're they're wanting to come in the pharmacy and interact. So it's just doing a lot of what we normally do, just doing it a little more focused and a little better.
Okay, so then staying on the financial theme related to patients who may not have insurance or who are underinsured, or also we had another question about those teenage patients who may be interacting with you via telehealth. Do you utilize their parents' insurance? Do you have patient assistance programs that you use for people who don't have access to appropriate insurance? How does that part work?
Yeah, it's a great question. If you're working with a 340B entity and the 340B entity is receiving revenue, I don't want to get too buried into 340B because it's a very lengthy conversation, but the patients are, the entity is receiving revenue from the fulfillment of prescriptions. A portion of that revenue is supposed to go to help the uninsured or uninsurable. So there's that. We have Gilead has a robust program for patient assistance. So Gilead is tremendously helpful in getting those who are unable to be insured to make sure that they're able to receive PrEP therapy. Now, when we get to those teenage, that teenage audience, yeah, it does become a little more interesting. The ACA allows children to remain on their parents' healthcare plans until age 26. In New Jersey, coverage of all HIV medications is mandatory, and there is no restriction. There's nothing you're not allowed to restrict access vis-a-vis. You can only go to a Walgreens affiliated mail order pharmacy. It has to be covered, and it has to be available at all pharmacies. So in Jersey, I don't normally say that we in New Jersey are lucky, but we in this instance, it's good to be in New Jersey. There's always that idea of what do parents know, what do they not know as far as this goes, because we can't currently, we as pharmacists don't have the ability to prescribe PrEP yet. That portion of it will be largely dictated by the prescriber who we're affiliated with. We have an APN that comes in. They'll have that interaction with the patient via telehealth, and the prescribers have a little bit better understanding of the landscape when it comes to parental notification versus HIPAA than we do as pharmacists. If in fact we are granted the ability to prescribe through either a standing order or through a collaborative agreement, yes, every person is going to have to look at what their state requires and make sure that when you're having that visit with a patient who's underage, that you're not running afoul of any sort of parental notification requirements that your state may or may not have. I don't believe that New Jersey has any prohibition on our interacting and prescribing PrEP to children under the age of 18. And I say children, I mean, nobody over 15 is going to be taking it. But yeah, there's no parental notification requirement. New Jersey is very liberal in that fashion.
Okay. On another topic, then, we had a question around perhaps extrapolating this model to other settings. So maybe within a health system, a community health clinic. Do you have any ideas about doing that, or have you seen this done at all in slightly different settings in the community pharmacy?
We haven't been able to find where this has been done, where it's pharmacy based. You obviously could have pharmacies within a PrEP clinic, but we've never had any sort of, we haven't been able to find any examples of where a pharmacy actually hosted the PrEP clinic. There are PrEP like practices that do have their own internal pharmacies. I see that largely in Pennsylvania. In New Jersey, it's a little more difficult. There's got to be certain firewalls between prescribers and pharmacies in the state of New Jersey that doesn't apply to every other state. As I said, in Pennsylvania, PrEP centers and PrEP community centers and LGBTQ centers, if anyone's listening from the greater Philadelphia area, Mazzoni Center is a good example. They have their own 340B pharmacy on site. That's allowed by their state. New Jersey doesn't allow it that way. For instance, you could have, I, as a pharmacist, can locate a doctor in my facility and own the space and everything. There's no problem. A doctor cannot own and locate a pharmacy in their space. So this model is built for the Jersey sort of arrangement where, you see CVS has a minute clinic. That's allowed in New Jersey, but it couldn't be the reverse in New Jersey. So it would have to be pharmacy based in New Jersey. But yes, this does exist where you have PrEP centers with their own in-house pharmacies.
So interesting. I was not familiar with the New Jersey state laws and how all that worked. So of course that would have to be tailored to everyone's specific state laws,
Right.
Which are different. Okay, so we've got time for one last question, and I think this is a good one for us to end on. And this question is about how would you suggest that another pharmacy begin exploring this model and how they could apply it to their pharmacy? So assuming they have the right population to serve, what are the key players that the pharmacy should partner with, and how should they get started?
Sure. Well, a lot of it is identifying and knowing your community. Obviously there has to be a need before you determine what sort of PrEP clinical work. New Jersey is very unique. We have the most affluent suburbs and populations in the nation, 5 to 6 miles away from the poorest. That's something you don't see very often. We focus, our focus and our practice is focused on Camden, New Jersey, which is at the poorer end of the spectrum, versus Morristown, which is the most affluent. So if you were looking to do this model would work if you did an LGBTQ concierge service program. We also have that. We didn't really address it in this forum too much, but when you offer a full suite of services to the LGBTQ community, that may work for a lot of pharmacies. And the vulnerable populations that you're looking for, maybe you don't have at-risk populations or vulnerable populations right in your immediate area. Because we're in Camden City, we're within walking distance from a huge concentration of vulnerable populations. So our model absolutely does accept and have the ability to translate to our affluent areas that are right next door to Camden. But our focus is on the vulnerable populations because that's where the greatest need is. So you really, before you start, you want to understand that difference. If you're going for your vulnerable populations, your collaborative partners are going to be different. We're partnering with Camden AHEC because they're working directly in those vulnerable populations. They have the contact. You want to make sure that the partner that you're bringing in has the ability and outreach into the demographic cohort that you're targeting. So let's say I'm only looking for, the Morristown client, which is the more affluent. Maybe it's the men who have sex with men. That's what that's really what the target is. My partner in that and my approach to recruitment of patients in that regard will be different. That's where we get into more utilization of an app. We get more into utilization of LGBTQ services in general as a whole. And PrEP is one component of that. So we market our concierge services to the community, and PrEP is one of those services. And that's how we would achieve, bringing these clients in. So the approaches are different. We have we're lucky and we have the ability to take two different approaches and be able to exercise both. But really, it's just like any other business. You want to know your community, know your population, and you want to be able to get to them where they are. And that was the whole concept of the pharmacy-based PrEP clinic, was getting to patients where they are. removing those barriers to access, making it so they could come in, they could feel safe, they could feel comfortable, and they could feel good about initiating a therapy that's going to enhance their lives. And it's also going to stem the spread of HIV and get us closer to that HIV-free by 2025 goal that the governors have laid out for New Jersey.
All right, well, thank you so much, Tony, for joining us today. Congratulations once again to your pharmacy for the award this year. I really enjoyed hearing about all the fantastic work that you're doing. I know our audience did as well. And we will be very interested to see how the model continues to evolve. So thanks for joining us. Thanks.
And, you know, Amanda, feel free to share the narrative that we submitted that talks a lot about what the model is. I know we're going to have the slide deck up there. And to everyone, my contact information will be on the, on the slide deck. Feel free to call or email me. The whole goal of what we put together here was for it to be replicable across any pharmacy and across any community. So this isn't something that's proprietary that, well, this is ours and we don't want anybody else. It's made to give pharmacies that ability to apply this model to their communities and affect positive change. And any way that I can help do that, I'm more than happy to do so. As I said, feel free to contact me if you have any questions. I'm more than happy to help.
All right. Thank you so much, Tony.
Thanks.
Got a few announcements here at the end. We could bring the slides up. So if you would like to learn more about medication use quality, specifically as it relates to prevention and treatment of HIV, I wanted to let you know that PQA is very excited to announce a new continuing education course that is for our medication use quality certificate program. So the program provides training on HIV-related measurements and strategies to improve medication safety, adherence, and appropriate use. PQA did specifically design this 3-hour module to provide the participant with tangible tools and experience to help begin improving the quality of HIV care upon completion of the program. So our new course, which is called Measuring Quality to Improve HIV Medication Use, is going to launch on September 7th, and CE credit will be available for pharmacists, technicians, nurses, and physicians. PQA is going to follow up with everyone attending the Quality Forum webinar today before this September 7th launch with additional details on enrollment. You can also visit pqa.ceimpact.com to sign up for their certificate program or visit the PQA website for more information. And I've actually got some links here for you I'm going to put into the chat. You're also welcome to email us at education@pqaalliance.org for additional information. And then in addition to that, we have several upcoming events here at PQA. First is our third quarter stakeholder advisory meeting. That is going to be held next Wednesday, August the 25th from 1 to 2 o'clock Eastern time. This is a members only staff hosted meeting, and we will share measure development and maintenance updates as well as engagement opportunities. The registration link is available in the member resources library on the PQA website. And then we will also hold a technical education webinar on Thursday, September the 9th from 11 to 12 noon Eastern time. This is also a members only staff hosted event where we will share information about the implementation of PQA measures within the CMS quality programs and beyond. Registration link will be available in the member resources library also on the PQA website, and you will be receiving email communication if you are a PQA member about how to register for that webinar. And we are also looking forward to the PQA Leadership Summit on November 10th and 11th in Arlington, Virginia. This year's summit is going to be a hands-on meeting where key leaders from PQA's member organizations will engage in a series of interactive discussions, and that is around the implementation, the feasibility, and the completeness of Blueprint PQA 2025. The key contacts from PQA member organizations received invitations earlier this month. And if you are interested in sponsorship opportunities, please do reach out to us at sponsorship@pqaalliance.org. I will put those in the chat for you here really quickly, both the website address to the Leadership Summit as well as that sponsorship email. And then finally, our next Quality Forum webinar will be on Thursday, September the 23rd. We will hear from Russell Robbins from Blue Health Intelligence and Magali Rodriguez de Bittner from the University of Maryland School of Pharmacy. They will share about how PQA and other quality measures are used in an analytics engine to examine care delivery and medication adherence, and also how pharmacists are using PQA measures to improve healthcare delivery and quality while meeting patient care and health plan goals. And then, as always, we value your feedback. Please do take the brief 1-minute survey that will appear at the conclusion of the webinar today. And then, as a final reminder, the recording and the slides will be available on the PQA website, as well as the recording on the PQA YouTube channel within the next week. Thank you all very much for attending the Quality Forum today, and have a good day.